thank you to Dr. Usoro for inviting me to speak at this wonderful meeting. So my talk is going to discuss bloodless care in emergencies and how this is possible and actually better care. And just so that you guys all know, as Sherry mentioned, my primary training is in emergency medicine. So I am an ER doctor, although I currently do not practice in the ER. I currently practice hyperbaric medicine and medical toxicology. So I had a lot of fun making this talk because it allowed me to include all of my specialties in it. So we're going to talk about, well, we won't talk a lot about hyperbarics because we discussed that at the last meeting, but we will talk a lot about toxicology and how the drugs that are available can be used in emergency settings to provide bloodless medicine care. So we're going to talk about the significance of anemia in emergency department patients. Why is this an issue? Why do we care? We'll talk about some of the drugs that can be used to treat these patients, as well as the non-pharmacological methods to manage anemia patients in the emergency department. I'm sure that you are all familiar with this already, but we'll talk about an ED perspective about ways to reduce unnecessary blood loss, as well as, again, something that you all are most likely familiar with, as well as effective methods for increasing red blood cell production in ED patients. I will say, as an ED physician, I can tell you that in the United States, there is essentially no training given to emergency medicine physicians about care of bloodless medicine patients. I think overall in the emergency department, we do a pretty substandard job, I would say, of managing these patients, just because in general, emergency medicine physicians are not equipped with the knowledge and the resources to treat this patient population. And so I'm hoping by giving this talk, this will be a little bit of a start to hopefully motivate some of us to go back to our practices in the emergency department and change our ways of doing things. So I'm going to start with a sample case, and this is an actual patient that came into our ED at MedStar Georgetown University Hospital a couple of weeks ago. It was at the end of April. So this is care that was provided to a patient at a tertiary care hospital in the US in April of this year. So this patient is 47 years old. She does not have medical insurance, but she's actually from Senegal, and she flew to Washington, D.C. from Senegal to get definitive treatment of her uterine fibroids. So this is important. I want you to all consider the social aspects of this case. So she's from another country, so she has no U.S. medical insurance. And so she was going to one of our gynecologists for management of her fibroids. So the gynecologist ordered some outpatient laboratory testing on her, and her hemoglobin was 3.6. So he called the patient, and the patient actually, again, she's not from here. She's staying at a local hotel in DC. And so the gynecologist said to her, hey, your hemoglobin is critically low. You need to go to the ER. So she came to the ER, and she came in by private vehicle. So whenever, I don't know how many people in the audience are ER physicians, but whenever we see patients in the ER, something that was always taught to me was you make a matrix. So you make like a checkbox, like a kind of a 2x2 box of, was the patient sick or not sick? And is the patient going to live, or is the patient going to die? So anybody that comes into the ED can be put into one of those groups. Remember, sick, not sick, live or die. And we'll come back to this over and over. So this patient, right away, we know she's sick, right? She has a hemoglobin of 3.6. So we know that she's sick. Now the question is she going to live or is she going to die? Because if she is in the sick and die category, or even in the not sick and die category, we want to make sure that we just treat her very quickly. She's going to need hospital admission, very prompt medical care. But if she's in the category of sick and live, or not sick and live, then we have some more time to manage her. She might not actually have an emergency medical condition. So the fact that she was living in a local hotel, the fact that she came into the ED by private vehicle and walked into the ED strongly points to me that this patient is sick, but she's going to live, because she did not come in extremis in an ambulance, for example. So in the ED, the patient did admit that she's fatigued and she has some shortness of breath when she goes upstairs, which is completely expected given her low hemoglobin concentration, but she was pretty stable. So her initial blood pressure in the ED was 141/81. Her initial heart rate was 109. So again, she's a little tachycardic, nothing to write home about. Her physical examination was completely unremarkable. She was probably a little bit pale, but it wasn't documented in the ED note when I looked at it. So again, thinking back, sick, not sick, live or die, I'm going to say this patient's probably sick, because we know that she's quite anemic and her hemoglobin was repeated in the ED, but she's going to live. Like, I'm not concerned that this patient's going to, die on me in the next hour of my ED shift, right? This patient will probably be able to survive very well and go on with her life. So the patient was admitted to the gynecology service. So the way that it works in my hospital is that the physician calls the patient into the ER and gives recommendations. And in this case, the recommendation was this patient needs to be admitted. She's severely anemic. So the ED rechecked the patient's labs and admitted the patient for blood transfusion. The admitting gynecology attending wrote in her note that the patient, and this is actually verbatim from her note, the patient will need at least 3 units of packed red blood cells to get to a hemoglobin level greater than 7. So that's what the patient got. There was really no other mention in the notes about what else, anything else that she needed. Everything else was kind of like, oh, well, she can get her fibers worked up as an outpatient, blah, 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 but she needs to get transfused at least 3 units. So she got those 3 units. She got those 3 units of packed cells and she was discharged home the following day. So I would ask to all of you, do you think that in April of 2021 in the ED of a tertiary care hospital in Washington, D.C., was this patient provided with the best possible care in the emergency department setting? I'm biased, obviously. I think that this patient probably could have gotten better care. And so I'm going to take you through a few things about why I think this care could have been improved and some things that I would love for my emergency department to implement in order to provide optimal care for bloodless medicine patients. So why do we care about anemia in emergency medicine patients, right? We care about trauma, we care about acute overdoses, we care about COVID in the ED, but we need to remember that anemia is a very common condition. And in the US, the prevalence of anemia is going up. So from 2003 to 2012, the anemic population in the US nearly doubled from 4% to over 7% of the population is anemic. So that's all well and good, but when we consider emergency medicine, the prevalence of moderate to severe anemia in the US also doubled during that time, during that 9-year period. So in 2003, only about 1% of the ED population, or sorry, of the US population was considered to have moderate to severe anemia. And 9 years later, 2%. So we know that there's more anemic patients in the US, and there's more patients in the US who have moderate to severe anemia. There have been studies that have looked at the prevalence of anemia in the emergency department, and almost a third of our ED population is anemic, which is kind of scary because we don't really manage it too well in the emergency departments in the US. And so then you might think, well, but we're really worried about the traumas and the overdoses and everything else. But really, the populations that come to the ED are these high risk groups for anemia. So that's going to be your pregnant women, your children, your women of reproductive age, and your elderly patients. These are all people that are seen in the ED on a regular basis. So we are seeing a lot of anemic patients in the ED, and we need to know how to manage them well. Emergency medicine is a little bit different than other specialties. So again, remember, sick, not sick, live or die. We have a very time-sensitive focus, and this poses some pretty significant and unique challenges to how we are able to manage bloodless medicine patients. So first of all, if there's a patient who's unstable with ongoing blood loss, that patient has a high risk of death without immediate intervention, whether that includes blood or not. Like, we have to do something. We can't just sit there and talk about it, and we don't have time to round for several hours and come up with a plan. We don't often have time to telephone our colleagues in another hospital. We need to make life and death decisions in the ER. If there are unnecessary delays to definitive care, that's going to result in adverse outcomes and or death. And so there's certain things that I've noticed. So I am active on a couple of social media accounts in emergency medicine. And I noticed that whenever there's a Jehovah's Witness patient case that's discussed, there's a lot of discussion about how much time was spent trying to convince the patient to get blood. Why doesn't the patient understand that blood will save their life? What can I do to convince this patient to get blood? Oh, nothing? Well, I'm just going to send the patient home and they can die. There's a lot of time that we spend trying to convince these patients to get blood, and this actually is not helpful. So this is actually causing delays in definitive care. And again, in emergency medicine, time is of the essence. We need to not try to take all this time to convince patients to get blood. Also, again, like I mentioned before, we are not really trained in our emergency medicine residencies in how to manage bloodless medicine patients. So if we can improve that, if we are able to give emergency medicine physicians more familiarity and knowledge about the techniques that can be used in the management of bloodless medicine patients, this will eliminate some of those unnecessary delays just due to people having to look stuff up or phone a colleague or something like that. So we do have a lot of work to go in the emergency medicine setting. Another challenge is that the initial identification of bloodless medicine patients can be difficult in the emergency department. So I always like to say, and there's exceptions to all of this, but for the most part, nobody wakes up in the morning and says, hey, this is a great day to go to the ER to get my appendix taken out. We see patients on their worst days and their worst possible scenarios. So what might be my best day, because it's my coolest case ever, is that patient's worst day of their life, right? Because it's the day that they had this emergency condition come up, they got diagnosed. So nobody plans to go to the ER for the most part. So that that trauma patient that comes in that's obtunded or intubated is not going to be able to clearly define his or her needs. Patients might not be able to say, I am a Jehovah's Witness. I do not accept blood. I will accept, X, Y, and Z, but I will not accept the 4 major blood components, right? They might not be able to clearly define their needs. They might be confused. So somebody might have been sent in from a nursing facility with urosepsis, and that patient might have been very talkative and very outspoken about their beliefs at their facility. But when they get to the ED, they're in extremis because they're in shock and about to die, and they're not able to clearly define their needs. That healthcare directive form that the patient may have very carefully folded up and put in their purse might not make it to the ED. So in a car accident, for example, belongings are frequently left at the scene. When the ambulance comes to bring you to the ER, they're going to ask for your ID and your insurance card, and they're probably going to leave everything else at home. And so patients will frequently not have their important medical information with them when they come to the ED. Also, in the emergency department, we are taking care of patients on nights, weekends, and holidays. And these are the exact times when bloodless medicine programs are not available. So even though your hospital may have an excellent bloodless medicine program like we do here at Georgetown, our bloodless medicine nurse coordinator is not going to be coming into the ER at 2 a.m. on a Sunday to see a patient. This is it's not feasible for one person to do all of that. So I always recommend that the hospitals use a blood product consent form in the ED. And this is something that can be done upon initial patient evaluation and registration. And it can actually, just having a patient, if they're able to, complete this simple form can actually take away a lot of the confusion about what the patient wants in terms of blood products, what the patient will accept. If the patient is not able to speak for themselves, or if nobody's able to be with the patient, then whoever brought the patient to the ER, whether it's EMS, there frequently will be a relative who comes in with the ambulance or comes shortly after the ambulance. The relative or the loved one can help fill out the form, knowing the patient's beliefs. So this is a typical form. This is what we use here at Georgetown. Probably a lot of you are familiar with this form. It's really just our bloodless medicine and surgery program patient instructions. And so it's pretty simple. You can see that the patient can just check boxes to accept or refuse the major blood components, the plasma-derived fractions, the white cell components, and then all the other little things that we never really consider in the ED that involve the use of blood. So something like a tagged white blood cell scan for a GI bleeder, an epidural blood patch for somebody with a post-dural puncture headache. These are not things that we would generally think about in the ED as involving the use of blood. We just think about transfusing red cells and FFP. But this form gives the patient the ability to, number one, think about it, and number two, be able to adequately and effectively communicate, even though they might not be in their best state of health. So I do recommend that this form is something that is utilized in the emergency setting. I'm actually not sure how many hospitals use this form in their EDs, but I think it's a really, really helpful thing to do. All right, so now the patient's in the ED, and now you're looking at the patient and you're like, this patient is sick and this patient may not live. So this patient is on the sick and die continuum of our spectrum. So they need emergency care right away. So in the ED, again, we don't want to sit there and discuss with the patient for an hour, like why won't you take blood, blah, blah, blah. We want to focus on goal-directed resuscitation and hemostasis. So I worked in Hartford, Connecticut for about 10 years, and I was at Hartford Hospital. About 40 minutes from Hartford Hospital is the town of Newtown, Connecticut. And some years ago, there was a pretty big school shooting where somebody broke into a school and shot and killed a bunch of first graders. That prompted my boss, who was the director of trauma at the time, Dr. Linworth Jacobs, some of you may know him. He met with a bunch of other individuals in the area, and they formed the Hartford Consensus, which you can see here at the top right hand of the picture. The Hartford Consensus came up with the Stop the Bleed campaign. And the Stop the Bleed campaign was initially designed to teach laypersons how to stop traumatic bleeding. So again, when the ambulances and the fire department rushed to the school shooting in Newtown, Connecticut, what do you do when you're faced with, 30 exsanguinating first graders? You can apply a tourniquet. And so Stop the Bleed really taught hemostasis. And that's something that's really important that we frequently don't address in the ED when we should in bloodless medicine patients. We spend so much time trying to tell the patients, take blood will save your life, that we forget that hemostasis is very, very important in saving these patients' lives. So things like early operative intervention, early endoscopy for the GI bleeders, IR embolization for patients if needed. These are things that can save patients' lives in the short term. There might be some pushback because, the anesthesiologist might say, hey, this person is too sick to get anesthesia. I would push right back and say this person will die if they do not get this endoscopy to stop their bleeding. They need an intervention to stop the bleeding. We don't have time to sit here and talk about it. Yes, it is a risk. It's also a risk for them to stay in my ED. So remember, resuscitation and hemostasis, very, very important. There's other things that we can do in the ED just as regular ED physicians. So this is just a nasal packing. So somebody comes in with pretty significant epistaxis and they are Jehovah's Witness, put a nasal packing in. It's pretty simple. We can suture wounds. Somebody comes in with a bleeding dialysis catheter and they are, that they're losing blood acutely and they will not accept blood products. Throw a figure of 8 stitch in there. There are things that we can do to stop the bleeding in the ED. It is important to remember that coagulopathy is enhanced in the presence of hypothermia. So when we are performing resuscitation with fluid for these patients, we do want to give our bloodless medicine patients warm IV fluids to reduce the incidence of hypothermia and the subsequent coagulopathy that can result from that. All right, so these are some of the initial things that we can do in the ED. Now I'm going to put on my toxicologist hat and shift to more of the pharmacologic therapies that can be used. So first we'll talk about tranexamic acid, or TXA. So TXA is a synthetic lysine derivative, and the way that it works is that it binds to the lysine binding site on plasminogen. So basically TXA binds to plasminogen, and by doing this, it prevents the conversion of plasminogen to plasmin. So you actually have inhibition of fibrinolysis. So normally TPA catalyzes the conversion of plasminogen to plasmin, and fibrin is another catalyst that speeds up the reaction. When TXA comes along, plasminogen can't bind to fibrin, and so this leads to decreased conversion to plasmin. And again, this inhibition of plasmin formation leads to a reduction of fibrinolysis. So that's a lot of words. If you're like me, you might just rather look at a pictorial of this. So here we go. So on the left side of the slide, we have normal fibrinolysis. So we have a nice little conformational binding here of TPA and plasminogen, and that allows plasminogen also to bind fibrin, and that results in fibrinolysis, and you have your fibrin degradation products down here, and everything is wonderful. When TXA comes along, remember it binds plasminogen. So it induces this conformational change in plasminogen that does not allow fibrin to bind. And so that really limits the speed of the reaction of conversion of plasminogen to plasmin, and it really just does inhibit fibrinolysis. So that's how TXA works. It actually is FDA approved in the US as a oral treatment for cyclic heavy menstrual bleeding. So think back to that first case that we talked about, the lady with the bleeding fibroids and the low hemoglobin. This could have been a great option for her, right? So there's a lot of literature about the use of TXA, and it was really popular maybe about like 3 or 4 years ago in emergency medicine. We were using it for everything. So, if somebody comes in with a, bleeding dental extraction and they are on warfarin, have them, take IV TXA, soak it on some gauze, have them bite on it. Look, their bleeding stops. We were soaking TXA in nasal packing, sticking it in people's noses for epistaxis. We were doing all sorts of things with TXA. It's sort of fallen out of favor in the ED setting because some of the more recent trials have not been showing such great results, but it's still available for use. So the best literature out there for TXA relates to heavy menstrual bleeding, as well as postpartum hemorrhage and acute traumatic bleeding. So I want you guys to keep in mind the first two indications, because when we talk about some other facets of, I guess, the demographics of bloodless medicine patient presentations to the hospital, these are two of the big ones. So the gynecologic bleeding is a major source of morbidity in the bloodless medicine population. So this is something that can be used to treat them, and it can be used in the emergency setting. Other indications include, for TXA, are going to include our high-risk surgical procedures. So our cardiothoracic surgery, our orthopedic surgery. Again, we spoke before about dental extractions. It's been used in patients who have hemoptysis, and also the epistaxis that we discussed. And again, this might sound minor, but if you are working by yourself in a small, 20-bed hospital in the middle of nowhere, and somebody comes in at 2 a.m. on a Friday overnight shift, and they are a Jehovah's Witness and they have massive epistaxis, I mean, you're responsible for the entire ER. So you can't just sit there and hold pressure on the patient's nose for 5 hours. It's just not going to work. So a TXA soaked nasal packing is actually a great option in this case. All right, so some of the problems with TXA. So the dosing is all over the place. So for some of the other drugs that we'll talk about, there's one dose. You give a dose and that's the dose that you get. For TXA, it's all over the place. So I remember a couple of years ago, people were going on social media asking, hey, what's the dose for TXA? Like what my pharmacy's asking, like what's the dose for dental extraction bleeding? And it's like, oh, just squirt some on some gauze and put it in their mouth. The dosing is not standardized. So in the US, for heavy menstrual bleeding, the dose is 1,300 milligrams orally 3 times a day. For postpartum hemorrhage, sorry, I put that PPH abbreviation there, but that means postpartum hemorrhage, as well as trauma, the dose of TXA is going to be 1 gram IV, and you can repeat this. You could even start a TXA continuous IV infusion if you would like. For some of the surgical indications, intraoperatively, patients are sometimes given 10 milligrams per kilogram IV. So again, you sort of need to know the literature. You need to know what you're treating, because the dose is going to be dependent on the particular conditions that you're treating. As with anything in medicine, there are adverse events that are associated with TXA. One of the ones that interested me was that TXA can cause seizures. So if you think about the actual mechanism of action, TXA is actually a GABA antagonist. And so GABA is a inhibitory neurotransmitter. And if we inhibit an inhibitory agent, then we get activation. So you actually get CNS agitation, and you can get seizures after administration of TXA. This normally occurs after high dose administration. In the literature, about more than 100 mg per kg. So more than 10 times your dose for the normal surgical indications for TXA administration. And you can also get acute thromboses. Again, so TXA does not promote blood clots; it more stabilizes existing clots and then inhibits fibrinolysis. But again, there is this concern that it can promote thrombosis formation. This has not really been noted to occur in multiple studies. So in multiple high volume orthopedic and I believe also cardiothoracic surgical populations, thromboses were not noted after TXA administration. All right, so that's TXA. We're going to move on to prothrombin complex concentrate. So This is a concentrated human plasma product. So some bloodless medicine patients may not accept it because it is derived from human blood. It contains at least 3 and sometimes 4 clotting factors. So in the US, we have 4-factor PCC. Other areas of the world might have 3-factor PCC. So it will always contain factors 2, 9, and 10. Sometimes you'll also get factor 7 in there as well. And overall, you basically get 25 times more clotting factors than you would get if you got just regular run-of-the-mill fresh frozen plasma. In the US, prothrombin complex concentrate is indicated for the reversal of bleeding associated with the use of vitamin K antagonists, so warfarin, for example. The dosing it's not as out there as TXA, but it's a little bit more complicated because it's based on INR and body weight. So this is the US prescribing information. You see that you look at the INR, your dose is based on that, but it does max out at a weight of 100 kilograms. In the US, the most frequently used prothrombin complex concentrate is going to be Kcentra. So here's a picture of it. You see that it does have that note on it that it is a human product. So it is a human blood product. We can consider the use of this in the ED setting for the treatment of acute bleeding in patients who are on warfarin therapy. So it's got a lot of advantages. This stuff is immediately available. I mean, we keep it in our ED Pyxis. We can keep it at room temperature. It doesn't require refrigeration. You have to reconstitute it, but this can be done pretty quickly. It doesn't take a lot of time. So you don't need to get your pharmacy involved in a lot of cases. Compared to FFP, it's a small volume of administration. So if you have somebody who's elderly, who has CHF, you do not have to worry that you're going to put them into a CHF exacerbation by infusing Kcentra. Doesn't require type and cross. So again, you're saving lots of time. You can do an ISTAT point of care INR and get your results and dose, get the patient's weight and dose the patient. You do need to administer it with vitamin K. So again, the clotting factors 2, 7, 9, and 10 are your vitamin K dependent clotting factors. So at some point, you need vitamin K to help out the whole process. So we do need to give vitamin K. And it is expensive. We'll keep that in mind. Cost is always an issue, especially these days in the era of the COVID pandemic. And again, because it is a human-derived product, it may not be acceptable to all patients. All right, so we're going to move on to one of my new favorite drugs, which is recombinant activated factor 7. So this is pretty cool. It's derived from hamster kidney cells. So it doesn't include any human plasma, doesn't include anything human-based, and so it should be acceptable to all bloodless medicine patients. It contains factor 7A. So, initially I'm like, who cares? Factor 7, I'd rather give 4 factors. I'd rather give 2, 7, 9, and 10. Why would you just want to give factor 7? Well, the cool thing about factor 7 is that it promotes hemostasis via the extrinsic pathway of the coagulation cascade. So it actually activates factors 9 and 10. So if you go back to first year of medical school, you take a look at this graph. So here's your extrinsic pathway. Here's your factor 7. When it comes into your coagulation cascade, it actually, when it's activated, it's going to activate factor 9 and factor 10. So you're actually getting 3 factors for the price of 1. This is great. This is a great product, I think. So in the US, this is the trade name, it's NovoSeven, and it's indicated for the treatment of bleeding in patients with the hemophilias, as well as this very, very rare platelet disorder called Glanzmann's thrombocythemia that I've never seen clinically myself. But it can also be used for treatment of bleeding in patients who are not able to accept blood products. Its dosing is pretty simple for the ED staff. It's very, very simple. It's weight-based. So 90 micrograms per kilogram IV. You just give it. Here's prescribing information with the dosing information. So you can redose it if you need to. But it's, for pretty much for almost every indication, almost every condition, it's the same dosing, 90 mics per kilogram. So that's just something that we can put in the back of our head and remember it. Again, similar to TXA, there is the potential for thrombosis. And again, this just goes back to the mechanism of action. So you are going to have the risk of promoting thrombin formation with activated factor 7. So you do need to assess the risk of that versus the benefit for the patient. But in many cases, in the emergency setting, somebody has life-threatening bleeding, this is going to be probably your best option, I'm thinking. So this has actually been studied. I actually was really excited to find this article. So this is an article that came out of Australia and New Zealand. And the authors they did a study of 3,000 patients who were treated with recombinant factor 7 for critical bleeding. And they were wondering, well, what is the outcome in the bloodless medicine patients compared to all comers? So of these 3,000 patients, there were 42 Jehovah's Witnesses that were included. They had many different sources of bleeding, including cardiac surgery. What's interesting is that look at these numbers. So almost half of the non-Jehovah's Witness patients had bleeding from cardiac surgery, but only about 19% of the Jehovah's Witness cases were cardiac surgery patients. The Jehovah's Witness patients were actually quite high in number in a couple other indications. That would be the obstetric bleeding and the medical bleeding. So the GI bleeding, the non-surgical bleeding, the non-trauma bleeding. So again, the obstetric bleeding and the slow GI bleeders, these patients are going to be disproportionately numbered higher in the Jehovah's Witness population. And so this is when we can really make an intervention, again, because we know these are patients who come to the ED. We know they're at risk for bleeding, and we can really use the available pharmacological therapies to make a huge intervention on this patient population. They also looked at trauma, but the numbers weren't as impressive as the medical and obstetric bleeding for the Jehovah's Witness patients. Please note again that in those two indications, the Jehovah's Witness patients outnumbered the non-Jehovah's Witnesses by about 3 times as much. All right, so about 2,500 of these patients got a single dose of factor 7. About 700 got one or more than one dose. What's interesting is that almost all of the non-Jehovah's Witnesses received blood transfusion as well as factor 7. So this article was actually kind of interesting because in this population, about 30% of the Jehovah's Witnesses also refused blood, which is interesting. The non-Jehovah's Witness patients were more likely to be hypothermic or have acidosis present. So this led the authors to say, well, maybe we're treating the Jehovah's Witnesses under less severe circumstances, but you could also argue, I think, that with the Jehovah's Witness patients, you're intervening sooner. And so you could make the argument that you don't need to wait for these patients, for any patient, to become hypothermic or have acidosis present, which are both indicators of a more significant severe clinical picture. If you know the patient's bleeding, treat them with factor 7 early on. Don't wait for them to get sicker. And maybe in the Jehovah's Witness patients, we're actually just giving them better care out front because we're treating them more rapidly. We're giving them definitive care faster than we are the other patients in the study. The bleeding response, or looking at how many patients stopped bleeding after they got factor 7, was recorded for about 90% of patients. And it was very, very interesting. Overall, no matter if the patient got blood transfusions and factor 7 or just factor 7 alone, bleeding stopped in about 75% of cases. So what does this tell me? This tells me that you don't need to give blood. You can give factor 7 and you'll have the same clinical response in a bleeding patient in the ED. It's pretty cool. In terms of the differences in outcomes, so about almost all of the non-Jehovah's Witnesses required ICU admission. Only about 3/4 of Jehovah's Witnesses did. So again, they're having better clinical outcomes already. They're not going to the ICU. The median ICU stay, the median hospital length of stay were also shorter in the Jehovah's Witness patient cohort. The incidence of thrombosis was about the same in both groups, about 10% overall. And the 28-day mortality rate was less in the Jehovah's Witness group. So this is actually showing that we're giving the Jehovah's Witnesses better medicine, right? We're not giving them blood, we're giving them factor 7, and they're having significantly better outcomes than patients who got blood. So that's pretty cool. So I would argue that in the ED setting for patients who have acute blood loss, and who cannot give blood, instead of sitting there trying to convince the patient to take blood because it will save their life, I would consider just very strongly giving them factor 7 right away. All right, so we're nearing the end. So let's see, what else can we do? So we've talked about a few of the drugs. We've talked talked about resuscitation. We've talked about rapid attempts at hemostasis. And then there's all the other things. So we want to reduce unnecessary blood loss. We want to enhance red blood cell production. We'll talk about those two things. I'm not going to talk about increasing the oxygen carrying capacity of blood. You guys all know that I practice hyperbaric medicine. I've got 4 patients in my chamber right now at Georgetown. This is a different talk for a different day, but hyperbarics works great in increasing the patient's oxygen carrying capacity. And we also, of course, want to lower the threshold for transfusion. So we know, again, going back to that sample case, we know that patient in the case, she was chronically anemic. She walked into the ED with a hemoglobin of 3.6. If she had acutely developed a hemoglobin of 3.6, she wouldn't have been able to walk in. She would have been confused. She would have been obtunded and a mess. So patients with chronic anemia from medical conditions are almost frequently always able to physiologically tolerate low hemoglobin concentrations. And so if somebody comes in with chronic bleeding and they're iron deficient, we can consider giving them iron replacement instead of blood. Probably better definitive care overall. All right, so let's talk about the ED care of patients to reduce their blood loss. So typical vacutainers that we use to draw blood in the ED, like you see pictured here, hold anywhere between 2 and 10 cc's of blood. It's very common in the ED to have all the tubes drawn on each patient. So whether the patient comes in and just needs a CBC, whether they need a CBC and an INR and a potassium or whatever, they're going to get a whole rainbow tube of blood drawn. And that's because you want to be ready, right? You're in the ED. These are emergency conditions. You want to be ready. If you have to send a tube, you want to just have it ready to go. This has actually gotten worse. So in the US, this is a very common thing. So you drive down the highway and you see these billboards that give your wait time to see an ED physician. And it may not always be a physician. It may be a nurse practitioner or a PA, but this waiting time is a huge thing in the US right now. So how are hospitals kind of getting around these wait times? How do you achieve an average wait time of 15 minutes if your waiting room is full of, 50 patients at, 1 o'clock in the afternoon in the ER? So what you do is you put a physician in the waiting room. So you have a physician or a mid-level in the waiting room seeing patients, right? They just see a patient very, very quickly. They're like, what's your condition? What are you here for? And once again, they go down the list. Is the patient sick or not sick? Is the patient going to live or is the patient going to die? Figure out that matrix. The patients who are sick and are about to die go straight back, get resuscitated, get immediate care. And the patients who are sick and who may live, they may get, triaged to, they may have to wait in the waiting room for an hour or so. And then the patients who are not sick and who are going to live can either be discharged straight from the waiting room, or they can just wait, a few more hours to be seen. So that waiting room ER physician evaluation is what gets these wait times down. Again, the wait time is not the time in which you are put into the actual patient room in the ER and get your x-rays and your CAT scans done. It's the time to see a physician. So because of these wait time metrics that we're facing, a lot of hospitals are just sending a nurse or a phlebotomist out to the waiting room also. And as soon as the ED physician sees the patient, they draw blood. And so it doesn't matter who the patient is. It doesn't matter if you're a bloodless medicine patient or if not, you're going to get blood drawn. So again, with these ED protocols, this is affecting our care of bloodless medicine patients because we're probably taking blood from them unnecessarily. So my recommendations for this are that ED phlebotomists should really wait to draw blood on bloodless medicine patients until the full evaluation has been performed. So yeah, you're going to lose a little bit on your metrics here, but you're going to do a better job of patient care overall because you can administer focused attempts at phlebotomy. You can draw only what's needed. For the bloodless medicine patients, again, we do this on the inpatient floors, but in the ED, it's great if we can use microtainers for all blood draws. This doesn't always happen because, on the inpatient side, we can put the sign above the bed. In the ED setting, you're going to have the patient identify as a bloodless medicine patient. Again, that goes back to having that form filled out when they check into the ER initially. Then you can identify the patient, put a wristband on them, and that could be the sign for the phlebotomist to say, oh, hey, I'm going to use a microtainer for this blood draw. Also, considering the use of point of care testing is great for the ED. We used to do a lot of these point of care. Here's an iStat, which basically just take a couple drops of blood and it gives you a result. This can be something that could be considered to reduce the need for any phlebotomy in bloodless medicine patients in the ED. All right, so we'll move on to talking about how to enhance red blood cell production. I'll go through this pretty quickly because this is something that I'm sure you guys are all familiar with. But iron deficiency anemia is the most prevalent nutritional disorder in the US, and it's also very common worldwide. And as we saw from that Australia, New Zealand article, in ED patients, especially in the bloodless medicine population, gynecological and medical or GI bleeding are very common ED presentations, and they're also very, very common causes of iron deficiency anemia. In the ED, though, we don't really treat iron deficiency anemia. We'll give blood. We transfuse blood for anemic patients, even if they're just simply iron deficient, and we'll tell them just take some oral iron. But really, if we can give these patients IV iron, it's probably a better alternative and better medical care. There has been at least one article put out, I think this one was from Italy, that showed that patients in the ED who are found to have anemia from iron deficiency, they were fast tracked to get IV iron in a hematology clinic. And this led to reduced hospitalization rates. It reduced medical costs because the patients were not being admitted for transfusion. And once somebody's admitted for transfusion, when they come back to the ER again in 6 months, when their anemia recurs, when they have additional, gynecological bleeding, the patient's going to say, hey, last time I was in the ER, I got a transfusion, and it's going to happen again. So stopping the transfusion cycle and giving the patients IV iron is going to reduce overall medical cost, reduce initial transfusion, reduce retransfusion, and reduces the rate of hospitalization. And it's definitive care. It's better definitive care. It's win-win for everyone. We need to be doing this more frequently in the ER settings in the US. So recommendations, again, in the ER, you're looking for something that you can do quickly. You're looking for a limited intervention that can be done rapidly. So a 1 or 2 dose infusion of IV iron is great for anemic patients with iron deficiency anemia. We don't really have concern for non-compliance. I mean, again, you're giving them 1 or 2 doses and they're done. They don't need a lot of follow-up. You don't have to worry about getting them an oral iron that they're going to take on a every other day basis for 6 months. These are some of the formulations of IV iron that we have in the US. And you can see that, yeah, we have several of them. Some of them can be expensive, but again, I would consider the cost of iron infusion and compare that with the cost of a hospital admission for 3 units of blood. And I'm pretty sure that the iron infusion is going to come out at a lower cost. And again, these are recommendations. These are infusion regimens that take only 1 or 2 doses. We all know about the erythropoietin stimulating agents that enhance reticulocytosis and that will eventually result in improvement in hemoglobin concentrations. The initiation of these drugs results in increases in hemoglobin concentration within about 7 days of administration. It peaks within about 14 days. So it's not going to be great in the ED setting because it's not going to give you an immediate outcome. So it's not as useful. But if we start this treatment in the ED, for someone who's being admitted, that will actually lead to a more rapid erythrocytosis because we're starting the process in the ED, and it will probably reduce hospital length of stay as well, again, because you're starting it in the ED. And here in the US, patients will board or stay in the ED, sometimes for a day or 2, waiting for an inpatient hospital bed. So starting this process in the ED can be helpful, even though the ED physician may have some frustration because they know it's not going to result in an immediate improvement in the patient's clinical condition. Something that ED physicians do need to be aware of is that the hospital formulary probably has more than one ESA. And it's important because, as we know, some bloodless medicine patients will not accept albumin, and some of these products do contain albumin. So it is important to know as an ED physician if your formulary has the Retacrit formulation or Aranesp, as these do not contain albumin. And again, I would recommend that in the emergency department setting that we do consider administering these drugs to patients who are being admitted, as it will hopefully decrease their length of stay and enhance their reticulocytosis. I'm about to finish up, but I do need to mention this. So implicit bias is something that it's been more recognized lately, but it's something that we still fail to negotiate on a daily basis. So implicit bias is defined as the unconscious actions or stereotypes that affect our understanding and our actions and decisions. So I might say, I don't like Dr. Spice because he's wearing a white shirt. and I'm going to exclude him because I don't like people who wear white shirts. And so that's just definitive bias. Implicit bias is a little bit harder to gauge, but it's really how we grew up, how we were trained, and that's how we practice in our daily lives. As medical professionals, we are used to transfusing blood products. It's how we are taught. It's one of the first things that we're allowed to do as an intern is write an order for transfusion. When we are not allowed to transfuse blood products, we get frustrated, we get angry. And that is what I mentioned at the very start of my talk when I was mentioning how, we spend inordinate amounts of time in the ED setting trying to convince patients that they need to take blood, trying to tell patients if you don't get blood, then you will die. And this is all based on how we were trained. This is our own implicit bias. And this can lead to disastrous consequences. There was one study that came out many years ago. It was a study of European intensivists, and 63% of those who were surveyed said that they would transfuse a Jehovahs Witness patient who was exsanguinating, knowing full well that these patients do not accept blood products. Their bias was to still transfuse. And even worse, 26% said they would never tell the patient about it. So we need to change this mindset. We need to realize that we can give very good care, superior care, often with better clinical outcomes if we do not give blood. And bloodless medicine patients are able to be treated very, very well in the emergency department and or ICU setting without getting blood products. And we're going to finish up with back to that sample case. So if you recall, we had the 47-year-old female who had uterine fibroids and a very low hemoglobin of 3.6. Again, she flew here from Senegal. She walked into the ED. She was a little symptomatic, but not too bad. So we know that her anemia was likely chronic in nature. She didn't really have severe symptoms upon her initial ED presentation. And she got admitted to the hospital and received a transfusion of 3 units of blood. So was this the best possible care? So again, I would say we could do a lot with this case. She's most likely got chronic iron deficiency anemia. We could have given her IV iron. I mean, you could certainly argue that she didn't need a transfusion at all. I mean, you could have given her, if you had to, you could have given her maybe 1 unit of blood, not 3, but 1 unit plus IV iron, or even just IV iron. And think about the cost benefit ratio here. So this patient was uninsured. She's not a US citizen. She will never get US medical insurance. And she is going to be stuck with a bill in a few weeks when she gets it for an overnight stay at the hospital, for critical care time in the ER, for getting 3 units of blood and a bunch of other lab workups as well, when she could have gotten outpatient IV iron. Also, in this case, I think we could have considered the use of oral TXA. It's actually indicated for her current condition, for heavy menstrual bleeding. And if she were severely symptomatic in the ED, if she were bleeding actively, I would have recommended giving her factor 7 as well. Again, because we know that the therapeutic outcome might be similar to that of receiving blood. So that's all I have. So I hope that we've learned that there are many pharmacological and non-pharmacological methods that are available to treat bloodless medicine patients in the ED. Remember that IV iron is great for these patients with symptomatic and chronic anemia from iron deficiency. And overall use of bloodless medicine techniques may result in a superior clinical outcome as well as a reduced hospital length of stay. So bloodless medicine can truly be better medicine in this patient population. If you have any questions, you can email me, you can tweet me, and you can always find me here by my hyperbaric chambers here at Georgetown. Thank you so much.